There's a study out this week that I think a lot of women are going to want to hear about, because the assumption that perimenopausal sleep disruption is just an annoying phase you push through and forget about. The data has something to say about that, specifically something to say about your brain decades from now. That's where we're starting today.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a good one today. 3 studies, all out of the NAMS journal this week, and all 3 of them are doing some actual work on assumptions I hear repeated constantly about menopause. Let's start with sleep. Specifically, the belief that sleep disruption during perimenopause is uncomfortable, yes, miserable, yes, but ultimately just a phase. You get through it, you come out the other side, and whatever cognitive fog you felt was situational, temporary, not worth worrying about in the long run. A study published this week in Menopause, the NAMS journal, is pushing back on that pretty directly. Researchers looked at perimenopausal sleep disturbances and tracked cognitive function in those same women decades later. Women who were frequently woken by menopausal symptoms during perimenopause showed measurably worse cognitive performance later in life. Not a subtle trend, a real association. Now, and this matters. The authors are careful. They call for confirmation in prospective studies, meaning this is observational data, not a randomized trial. We don't have the kind of evidence yet that lets anyone say bad sleep in perimenopause causes cognitive decline. What we have is a meaningful association and a signal that's worth taking seriously. The kind of thing your doctor would want to see in a tool like open evidence, solid enough to factor into clinical thinking, not definitive enough to be the final word. What I actually think, though, I think we've been underselling perimenopausal sleep disruption for a long time. The framing has been, it's real, it's rough, here are some strategies, which is fine as far as it goes. But there's been very little urgency attached to it from a long-term health standpoint. This study is one of the early pieces of evidence that suggests sleep in midlife isn't just about quality of life right now. It may be a legitimate marker for what's coming later. That reframing matters. A woman who's told your sleep matters for your brain 20 years from now is going to have a different conversation with her doctor than one who's told, yes, that's normal for perimenopause. Whether that changes what treatment looks like is a separate question, and an important one. More on that as the research develops, but the first step is recognizing that perimenopausal sleep problems belong in the conversation about long-term cognitive health, not just symptom management. Staying with the cognitive theme, because there's a second study this week that adds a layer I was not expecting. Statins, specifically what happens to postmenopausal women who are taking them. Statins are one of the most prescribed medications in the world. For postmenopausal women, they're often recommended for cardiovascular protection. Heart disease risk goes up after menopause, and statins have a solid evidence base for reducing that risk. The fear that circulates online is that statins cause dementia or cognitive decline. That fear, according to this new study, is not what the data shows. But here's where it gets complicated. The same study found that statin use in postmenopausal women was associated with poorer, delayed recall memory and worse visuospatial function. It was also linked to a higher burden of menopausal symptoms and greater sarcopenia risk. That's muscle mass loss, which is already a real concern in postmenopause. So We've got a study that debunks the statins cause cognitive impairment narrative in one breath and then flags specific memory and function concerns in the next. That is not a contradiction. Those are two different things, but it's the kind of nuance that gets completely lost when this research reaches general audiences, because the headline will almost certainly be one or the other. Either statins safe for memory or statins linked to memory problems. Not both, not the actual picture. What's really clinically interesting here is the overlap problem. Statin side effects, cognitive effects, muscle effects, somatic symptoms can look a lot like menopause symptoms. If you're a postmenopausal woman on a statin and you're experiencing brain fog, muscle weakness, fatigue, or a worsening of other symptoms, the attribution problem is real. Is it the menopause? Is it the statin? Is it both? A 5-minute appointment is not going to sort that out. I'm not saying don't take statins. That's not my lane. And cardiovascular protection is not a trivial benefit to walk away from. What I am saying is that postmenopausal women on statins deserve a provider who knows this overlap exists and is looking for it. That's a reasonable ask. It's also based on how most of these appointments actually go, not always what's happening. The third study is a different kind of thing entirely, and I want to give it some space because it touches a part of menopause that still gets remarkably little airtime. Genitourinary syndrome of menopause, GSM. If that term is new to you, it's the umbrella for vaginal dryness, vaginal atrophy, urinary symptoms, pain during sex, tissue changes, all the things that happen to the vulvo-vaginal and urinary tissues when estrogen drops. It affects a large proportion of postmenopausal women. And unlike hot flashes, it doesn't tend to go away on its own. It typically gets worse over time without treatment. Treatment options exist. Local estrogen is highly effective and, it's worth noting, has a much more favourable safety profile than systemic HRT for most women. There are also non-hormonal prescription options, but plenty of women either don't have access, don't want hormonal options, or, and this is the one I find genuinely frustrating, don't know that treatment exists at all because their provider never brought it up. The study published this week is a feasibility pilot, emphasis on pilot, testing a negative pressure device called the Vita AV system for GSM. What negative pressure treatment does essentially is use suction to increase blood flow and stimulate tissue in the vaginal area. The researchers found it was well tolerated, no safety concerns, and women reported symptom improvements alongside favourable changes in objective assessments. I want to be clear about what this is and what it isn't. Small pilot study, no control group mentioned. The authors themselves say larger controlled trials are needed and that they want better follow-up on the time course of improvements. This is not a device that's ready for a recommendation. It's a device that cleared the first bar. It didn't hurt people and something seemed to happen, which is exactly what a feasibility study is designed to show. But it's worth tracking because the honest situation with GSM right now is that the gold standard treatments work for many women and are inaccessible or unwanted for others. The field needs more options. Non-hormonal devices with an actual evidence base, even an early one, are genuinely worth watching. And the fact that a study like this is getting published in the NAMS journal means at least some of the right people are paying attention. What I push back on gently is the tendency to either overclaim or dismiss these early findings. The overclaim usually comes from the device company. The dismissal usually comes from people who read pilot study and stop there. Neither is useful. A small, well-tolerated, early study on a condition that's undertreated and under-discussed is doing something valuable. It's keeping the door open for more rigorous work. If you're dealing with GSM and you feel like your options are limited, that framing is worth pushing back on with your provider. The treatment landscape is genuinely expanding, even if it's expanding slowly.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.